Morning, everyone. I welcome you all to this IC on HIV and I for the comprehensive ophthalmologist. Uh, Today in this IC we have discussing few topics relevant to the comprehensive ophthalmologist when we are dealing with, especially with the HIV patients. We try to be very simple, and you can ask any questions in between also. Here is the problem actually. If you see and look at the HIV or the AIDS population, we are number three in the world actually, behind South Africa and Nigeria, and this is something amounting something like 20.9 lakh of patients of HIV there in our population, and there is a varied kind of a distribution all over the India actually, and due to various reasons. So we are seeing these patients regularly in our clinics, announced or unannounced actually. So as we all know that HIV can infect the eye at any point of time. Something like 50 to 100% of the lifetime cumulative risk is there of the lesions there. So these lesions are seen usually in the late phase of disease, or their early manifestation. Like sometimes the ophthalmologist becomes the first guy to pick up these lesions in these patients, because these patients may be healthy there and they don't have any of the symptoms. So because of this reason, so you have to be familiar with these patients. We have to be familiar with the systemic clues, that what to look for, how to suspect that this patient may turn out to be a HIV positive patient, and what are the ocular things if you see in the eye and you are not able to correlate with the other findings, whether you suspect seropositivity or not in these patients. So in this, I see with me are Dr. Amit Gupta. He is additional professor and looking after cornea and PGI. Dr. Sunil, he right now he's in AIMS as assistant professor, and Dr. Diksha, she is assistant professor in PGI MER. So I've designed this course. I'll be talking about few clues there to how to suspect that this patient may be a HIV positive patient. And of course, as I've already said, because any patient can turn out to be a HIV patient, he may not announce to you that I'm a HIV patient, and legally he's safe and he need not announce to you. So we need to follow some universal precautions in our clinic and in our surgery also. So we cannot get HIV testing for all the patients. That's not recommended there. So universal precautions are must in clinics as well as the OR there. So Dr. Sunil will be taking up in the clinics, and Dr. Diksha will be talking about the surgery in these patients, how to take care during the surgery. And Dr. Amit will be talking about the common anterior segment problems, and I'll be elaborating further on the posterior segment. So are the clues there which I was talking about. So like this, I'll start with the cases here. Like if you have a patient there who presents to you like this, like a 37-year-old male, he presented with the 20/20 kind of a parts vision, blurred vision because of the PSC there. He had a posterior subcapsular cataract. I was more interested in these cotton wool spots actually, because I saw these cotton wool spots there in the eye, and this patient said, I don't have any diabetes, no hypertension, there are no other features in the periphery, nothing is there. So I asked them in retrospect, what do you do actually? It turned out to be truck driver. So my antennas were up. That's something I have to look for. I have to because they don't appear just like that cotton wool spots or the microangiopathy there. So this patient, next time he came to me after 4 to 6 weeks, but turned out to be a seropositive patient. He had this CD4 of 96, but they are known to resolve on their own most of the times. But we need to follow them because they can be precursors of CMV retinitis also. Because CMV retinitis also occurs below CD400. So it is important to follow these patients, like if not weekly, bi-weekly, so that these cotton wool spots will typically merge and form a CMV retinitis kind of a picture. But seeing a cotton wool spots or microangiopathy in any patient, you don't ignore it. Just try to find out the cause of what is there in this patient. So this could be one clue there in these patients. Similarly, another patient, he was there for complaint of floaters there. So we were doing this indirect fundus examination, and we saw this one lesion here actually. So again, a non-diabetic, non-hypertensive. But in this patient, we did not ask for, we missed this. We thought it's a subtle lesion. We didn't ask for any HIV history or nothing. But we should have, because this patient, next time he came with this kind of a, so this whole one lesion has become this whole vasculitis of the cord has appeared now. So we missed this patient here. We ignored this lesion. We did not ask for anything, but he developed this lesion. Now we got the HIV done. Now we know that there's something is happening in the periphery, and he turned out to be HIV positive. CD4 was there, because if you see a lesion, a cotton wool spot appearing into a vasculitis or a CMV retinitis like picture, you need to get the HIV done with this patient. And with the treatment, he recovered very well. Next are these kind of patients. These patients, this was a 47-year-old male, a policeman by profession. He came with a complaint of blurred vision in the left eye for a couple of weeks. Of course, if you have seen these kind of pictures, you have this is a picture classic of a exudative CMV retinitis. You are seeing these lesions there, which are coming from the periphery, and there is a trophic edge and there is a leading edge. So in this kind of a patient, you suspect CMV retinitis, and CMV retinitis you don't see normally in immunocompetent patients. It has to be a immunocompromised patient. So compromised, you ask for the kidney transplant, bone marrow transplant, and next thing comes in the HIV. Okay, and the other eye was, of course, the posterior segment examination was normal there. So you got the HIV done, turned out to be positive. So any patient of this kind of a retinitis, which is peripheral, looks like a CMV retinitis, you need to investigate them for HIV, these patients. How to differentiate them from the kind of a picture of acute retinal necrosis or posterior outer retinal necrosis? We are not seeing much of vitritis here in these eyes, because arm will present more of vitritis kind of a clear media, not much of a reaction, just this much of retinitis without any vitritis. We should suspect that this patient might be a seropositive patient, which he turned out to be, and with treatment they normally do all right there. Again, this kind of patient, these patients they keep coming to our clinics because the CMV retinitis kind of inflammations are very slow growing, and they can be like the common cold. If they are in the periphery, the patient will not notice it. They will get healed spontaneously also if they are not involving the optic disc or the RD doesn't occur. So they come and heal on their own. So this kind of a picture is very important in these patients. So this patient was 42-year-old male. He was 20/30 in this eye and PL in this kind of eye. So when we were looking for the pale disc, then we saw the periphery, and we saw these atrophic patches in the periphery where the choroidal vasculature is very clear. Okay, the patient was a known case of HIV, but he did not disclose it to us. But when we asked him retrospectively, do you suffer from any such disease, then he disclosed that. So these kind of atrophic patches are classic of healed viral retinitis. If you have bacterial retinitis, they heal with a lot of pigmentation. They don't heal just like that. Viral retinitis heals with just atrophic patch where you are seeing the choroidal vasculature much more clearly than the rest of the retina. Similarly, these are the classic. When the lesions of Ahn they heal, they typically leave these kind of the peripheral tongue-shaped lesions. These lesions should not be missed. Peripheral lesions. They should. This was a patient who had 20/80 vision. He presented with PSC and he had some vitritis. We suspected it to be inflammation there in this eye. But when we look at the periphery of these eyes, okay, so we picked up these lesions in the periphery, and these lesions are classic atrophic patches, which we should rule out HIV positivity in these patients. He turned out to be HIV positive in this case. Of course, this is very important finding. If you are operating any patient of retinal detachment, and there was media was not clear, and he had a complicated cataract there, kind of a situation. Like this gentleman, he was 34-year-old male, one-eyed only, other eye already thiazical, and BCA was hand motions, right eye had cataract, and the vision loss was gradual over 4 months, and he USG had RD. When we went in, we operated this eye, then during the surgery, we saw these atrophic patches actually. So these atrophic patches are classic patches. If you see this is a macula, and this whole is an atrophic patch. You see classically the atrophic patch, and near that you see a break. These kind of atrophic patches with the normal healthy retina and breaks in between are suggestive of basically some retinitis insult which has healed and led on to the RD. And this kind of a patient, you should suspect that probably they are seropositive, they are immunocompromised. So they are the patients where you should get the HIV positive done. So you see that during the surgery also you get these surprises. We don't get HIV for these patients because this is not recommended. But if you see such things, you should suspect these, and the patient can come out with the risk factors, or he may simply deny it. Nobody will agree to what but he was advised HIV testing after the counseling. He turned out to be HIV positive. But the clue here is the atrophic retina, and with the RD, you should always think of the seropositivity in these patients. And of course, whenever you see this kind of a devastating vasculitis, what we call it as a frosted branch angiitis, it is a differential diagnosis. You see this HIV is the differential diagnosis. In any case of frosted branch angiitis where the vasculitis is massive, it is compulsory to get a HIV test done. This patient had a hand motion vision. Left eye was 20/20. Known drug addict when we saw the history. He turned out to be positive, but he was PL hand motion, but he came around 3 weeks later and with a note that he's HIV positive. But by now he has, because of this massive obliterative disease, he had bled and he has turned out to be PL negative. So in case of a frosted branch angiitis, the differential diagnosis is HIV has to be ruled out, apart from the other the virals and toxo other lesions actually. Similarly, this kind of a patient, this was a 48-year-old male who presented to us with a diminished vision in the right eye first, then in the left eye. So he was PL plus in the right eye. You see this kind of a retinal detachment is there. The PVR D1, the disc was visible, and once you see the other eye, the picture is clear. So once you see the other eye, you see a detachment there. But with the detachment, what we saw was an atrophic area here. So atrophic, again, the atrophic areas with the retinal detachment, again, we thought of HIV positivity in this patient, and this patient turned out to be HIV positive. And he was operated, and this much we could salvage his vision 200 and 2000 actually. So the presence of atrophic retina gives us the clue that probably you are looking at a seropositive patient. Again, the similar patient, right eye was involved first. This is classic in these patients that they have a presentation which is bilateral. Right eye, one eye they will ignore. They will come only when the second eye is involved, because they are somehow they are not that educated, or there are social problems. There are issues there with these patients, and they might not disclose to you that they are positive actually. So again, the clue here was there in the other eye. Other eye, we could see the atrophic patch there, and if you can clearly identify, you could see the breaks there. So the breaks, classically, you don't have to look for them very, it's very easy to look for them. They will be there at the margin of the healthy and the non-healthy retina. At the margin where the healthy retina starts, these atrophic patches will open up and the RD will occur. So this patient, we got the clue from the other eye that probably we are looking at a seropositive patient. So he again was a truck driver and turned to be seropositive. This patient, this is one of the Dr. Diksha's patient. This is again a classic case, a bilateral presentation, drop in vision, right eye, then left eye in a female, and we couldn't reach any diagnosis. We did a diagnostic vitrectomy for this patient because of the bilateral retinitis picture, and we thought of HIV. We got the HIV test also done, and she had a mixed infection with toxo and VZV. And what we have to remember is a classic toxo lesion is unilateral and it's unifocal. But if you see multifocal lesions and if you see bilateral involvement, think of HIV, because in HIV, toxo lesions will be multifocal and bilateral. So this was a patient who had a toxoretinitis and turned out to be HIV positive. Again, this kind of a picture, if you see herpes zoster in any adult, it is known that our medicine colleagues in adults, if this herpes zoster occurs, they get a mandatory HIV test. So is this patient. This patient has this herpes zoster there, and he was again one-eyed. But this patient had other clues also in the eye, because but I just wanted to show that a zoster in an adult should need HIV testing in these patients. This patient had a progressive outer retinal necrosis, and our diagnosis was we became more it has to be seropositive, it has to be immunocompromised patient. He turned out to be a HIV positive patient, and this is how we respond to the treatment, but they don't do well because the involvement is massive, the disc is already involved in these patients. So I will, what I will say is clues there you have to look for is again the microangiopathy and the atrophic lesions are the classic. You should not, these kind of patients, they require any patient with a floater, any patient with any one-eyed patients, and they all need peripheral fundus examination of the other eye also, so that you pick up the clues like atrophic lesions, clues like the Moore lesion, and zoster I've already said. Then systemically also, these patients are sick patients. You are thin, frail, pigmented, and failure to thrive kind of patients. You should not miss them in your clinic actually. Thank you very much.